Jim, what's the story?
It's a 71-year-old man, history of CVA, found unconscious at home. All we got now is agonal breathing. I'm assisting his breath right now.
We got vitals?
Vital signs are unstable, no respiratory rate. Blood pressure is not able to get a blood pressure, a palpable blood pressure on him yet.
Sir, open your eyes! Open your... Alright, can we get him, Doc, can we get him set up for RSI?
Okay.
Get me, Jim, can we switch places?
Yes.
I need the glide scope. Let's get 20 milligrams of etominate, 160 of suctional choline, and let's get some of the oxygen.
Do you want me to just give you this bag?
What's that?
Do you want me to just give you this bag? I mean,
I can't hear you.
you want me to just give you this?
Yeah, thank you. Can you plug in that glide scope? So that's all the history we got was CVA?
CVA,
Okay, found down?
found out.
Okay.
Just brought the hospital like 5 minutes ago. So.
Alright.
We've got IV access. How much accommodate do you want?
Let's draw 20 milligrams of etominate. Don't push it until I say it out.
Right.
EMS did say that there's a mom and a daughter. They're on their way.
Okay, we got any allergies? Probably don't.
Not that we know of.
Okay, perfect.
Is it on?
Alright, it's not on. That's okay. Can I get me a 7.5 ET tube?
7.5.
I'm bagging easily. I'm getting good chest rise and fall.
Can you do a blood pressure? And can we get him on the, oh, you can do it on the monitor. Alright, he's hypertensive.
He's hypertensive. He's about 210 right now. He's solid 110. Here's 7.5.
Thank you.
I'm ready to go whenever you want me to push.
Okay, actually, ooh, Jim, jump over 1 second.
Yep.
Okay.
What meds do you need for your RSI?
I think we've got them, but so it should be 20 to etominate, 120, 150 of suctional choline.
I've got the meds here.
All right, go ahead and push them.
Okay.
So etominate first,
Yep.
then suctional choline.
Accommodates in. Sucks is in.
All right.
He's flushed.
Okay, I think we've already got apnea. Hop off for a second. He's pretty loose. I'm just gonna take a look.
No.
All right, I can see cords. I'm in.
I'll need a syringe to inflate that.
Jim, can you inflate that? Yeah, please inflate the ET tube. Thank you.
Got breast cells.
What are you hearing, Jane?
It's good.
I have positive color change.
Positive color change. All right, great. So this is sudden catastrophic ultramental status. Let's. Looks like our vitals are unchanged. Let's go ahead and start a propofol drip on him. Let's do propofol drip for sedation, and then let's get him to CT. Oh boy.
Blood.
Yeah, so this is an intraparenchymal hemorrhage. He's got midline shift and intraventricular extension.
Yep.
This is devastating. Mm-hmm. I had to call neurosurgery.
Right.
And do you know if there's any family here?
There is. They've gotten here. They were on their way. EMS called them, and they're here now, and they're really chomping at the bit to know something.
Yeah. Okay. Let me. Can you just let me know that I'll be there? I'll call neurosurgery. And do we have spiritual care, palliative?
Yeah, we can get them. They're here in the house, and we'll certainly do that.
Yeah,
and then I'll kind of collect everybody together in that conference room.
Yeah, I'll see you in there.
Okay, good deal. Thanks.
Hey, it's Graham Snyder.
Hey, Graham, it's Dr. Jenkins from Neurosurgery. Hey, I was looking at the films on your patient down there.
Yeah.
Yeah, this is an unsurvivable injury. I don't know that there's going to be a surgical answer to this particular problem.
Yeah, that's what I suspected. Do you think without surgery there's a chance for a meaningful recovery?
Honestly, no. I think that this is a catastrophic bleed, and he's not going to get any better at all.
Okay. The truth is that's what I suspected. I was just going to tell the family that my recommendation would be comfort care measures and consult palliative care. You think that's too aggressive, or does that sound good to you?
No, I concur with that. I think palliative is probably the way to go at this point.
All right, that's what we'll do. I appreciate you taking a look.
Yep, you bet. Have a good night.
You too.
Hello, everybody.
Hi.
Hey, hi, Monica. I'm
Hi,
so glad to
Jane.
see you here already. I'm Jane Owen. I'm a nurse here in the emergency room, and I've been with your, is it husband?
Yes,
Tell me your name.
Milo.
Milo, nice to meet you, and you are?
Sophie.
Sophie, and what is your relationship?
That's my mom.
Okay, so that's your
That's
dad?
my dad, yeah.
Okay. I know the waiting has been really hard. We've been trying to get a group of people together to come and kind of support you guys, because I know this is very overwhelming, to say the least. So we have a group of folks coming from our palliative care service, and that's care for people who are very sick, seriously ill, and really need to have a lot of support for the family. So that's what we're here for. Also to give you information, because I know you're just thinking, what on earth is going on? And we're trying to find out some of that right now as well. So when we all get together with you, we're going to be able to give you that and answer your questions, okay? Is there anything else I can do for you right this minute?
I don't think so.
Okay, have you guys eaten today? I see your water.
I'm okay.
Okay, all right. Well, they'll be coming very soon, and then Dr. Graham right now is on the phone speaking to the neurosurgeon. And so I think I know from your dad's history, what I saw in the chart before, that he's had a stroke in the past. Is that right? Okay.
Yeah.
Okay, good deal. We'll get with you here in just a few minutes, okay?
I'll wait with you.
Thank you, Monica. Again, we've got our group here.
Okay.
Hey, everyone. This is Leah Rosen. She's one of our social workers.
Hi.
This is Angela Lewis.
Hi.
She is one of our PAs, and she is with the palliative care team. Okay, so part of their role is to sort of guide you guys through this and try to answer as many questions as they can, and they can start talking to you while we're waiting for Dr. Graham. Dr. Graham is going to be here shortly, and he's going to have a lot of medical information, and part of what palliative care does, I know, is to help kind of make that clear so it's understandable, not just medical language. So we'll help with all of that so you won't be confused.
Okay.
Okay?
Okay.
Thank you, Jane.
You're welcome, Angela.
Hey, Dr. Graham.
Hey, Jane, how are
I've been
you?
waiting for you. Everyone, this is Dr. Graham. He's the emergency room doctor.
Hi.
Hey, how's everybody related?
I'm his wife.
Okay.
This is my mom. It's my dad.
Okay. Yeah, so I'm Dr. Snyder. I'm the emergency doctor. So I took care of your dad when he came in. What did you guys hear about what happened?
Nothing. Our neighbor just called and said that they had taken him to the hospital. We were out running errands.
Okay. Well, what happened was he suddenly became unconscious and had a big stroke. The paramedics picked him up and brought him here, and he's critically ill. When he came in, he was really barely breathing, and so what we did was we put him on life support. We put a tube into his lungs to breathe for him, and gave him medicines to make his blood pressure stabilize. However, when we look at the scans, he's got a massive amount of bleeding on the brain. He's as sick as a person can be and still be alive. I hate having to give you guys this information, but I just talked with our neurosurgeons, and they said that unfortunately this is an unsurvivable injury. I know. I can't really imagine what you guys are going through, but
Is he hurting?
I don't think so. The amount of hemorrhage he had was so devastating that I believe that he is deeply unconscious. That said, just because he's terribly injured doesn't mean we still can't do some things for him. And what I did was I gave him some medicine to help for pain, if he has any, and I don't know.
Okay.
But we have a team here of doctors and nurses and nurse practitioners who care for patients who are this sick, and they really specialize in the care of patients that are devastatingly sick. And I really wanted you guys to tell them a little bit more about things we can do to help their family member.
Of course, absolutely.
Wait, but where is he now? What's going on?
So he's in the emergency room, which is just a couple 100 feet away. He's on the breathing machine, which means that he's got a tube in his lung that breathes automatically for him, and he's sedated with medicines, to prevent pain and suffering.
Okay.
I know that this is so much information for you two to process. Share with us what's going through your head right now.
I'm just worried about him. I know that he's had a stroke in the past, and not this, but we've been through something like this before. He did not want to be kept alive by tubes. But I'm just worried about him, and I just don't want him to suffer. I'm not ready to let him go.
Of course.
We're here to support the two of you and to talk through how we can best care for him, given what you just shared with us about his history and what's important to him. And that's why we're here.
Sophie, it sounds like you've spoken with your dad about some of these hard decisions in the past. Share with us what conversations you've had.
Well, the last time he had a stroke, just in case something were to happen again, we talked about what he would want if he couldn't say what he wanted.
Okay.
Filled out something, didn't he?
Yeah,
we have advanced directives.
Okay.
I think they're somewhere on my phone if you need to see them. But he said he didn't want to be kept alive by any sort of machines. He didn't want to have a tube in his mouth or anywhere, and he just wanted to not be in pain and just go.
What I'm hearing, it sounds like your dad was very clear that this quality of life with the tubes and all of the IVs and drains is not consistent with what he would want for his body.
Yeah.
Okay.
Right, Mom? Yeah. You're right. I'm not ready either, but
This is
I
so
know this, so go ahead.
thank you for being here.
I want to talk you through what that process looks like so that you kind of know what to expect and that there are ways to honor your dad and your husband's wishes. And what that process would entail is liberating him from the ventilator and these interventions in the emergency room, and accepting that he's at end of life and allowing his body to go through the natural trajectory. And instead of using our medical tools to keep him alive here on earth, we would use our tools like our medicines to ensure that he's comfortable and safe and dignified as he transitions between life and death.
Can we see him?
Of
Can we be
course.
with him?
Of course.
I don't want him to be by himself.
Absolutely. Share with me a little bit about your family and those that love Ted.
We've been married almost 40 years.
Oh my goodness.
I can't imagine being without him. And he had so many friends. He plays golf all the time, and he had a great job as an engineer for so many years. What am I gonna do?
If you all feel ready, we'd like to talk about how we might best care for your husband and your dad at this point.
Okay.
Yes, please.
Okay. We're here to walk you through this.
Okay. Thank you.
Of course.
So the process that I spoke about a little bit earlier of really liberating him from the ventilator and the medicines that he's on right now to maintain his blood pressure and to essentially keep him here on earth. We're going to slowly start removing those interventions, including removing the tube. And what that will do is put things in his body's hands. And what we expect is that his body will go through the changes that we see as one approaches end of life until he dies, until he passes.
How long does it take?
It's a good question. And ultimately, none of us can give you that answer. I will share with you that based on the devastating injury he suffered, the medical team feels that his time on earth will be very short once we remove these interventions. He may live seconds, minutes, hours, but because of the damage done to his brain, we don't feel that his body's going to be able to sustain itself for very long.
Thank you. When we take the tube out, I know that Dr. Snyder said that because of his injury, he probably doesn't know what's going on, but can he still feel pain? Is he gonna be scared? How are we gonna keep him comfortable?
So we're going to use medications through the IV to make sure that symptoms of anxiety, shortness of breath, pain are all going to be controlled. And our goal is that those medicines get him to the place where he can be comfortable and you all can be at the bedside with him, holding his hand, listening to music he enjoys, praying with him if he's faithful, doing all of the things that it feels right for your family to be doing with him.
Okay.
But when that time comes, you all will have the opportunity to go and be at the bedside if you'd like. Dr. Snyder will remove the tube from him and take him off of the ventilator. We will get all of the other lines and drains off of him and kind of demedicalize him so that he looks like the person you all know and love. At that point, we will make sure that he has medicines on board to control any symptoms that he starts to experience. Now, there are some symptoms that we see more commonly than others when folks are at end of life. So I want to talk you through a little bit of what that looks like. A lot of times, especially when folks have had neurologic injuries like your husband, we can see that they have shortness of breath or difficulty breathing once the tube is removed. So we use medicines through the IV to help manage that so that folks aren't breathing so hard.
Okay.
And I would love to be present with you and offer
Please.
that level of support if that's okay.
Yes, please. Thank you. Thank you. Okay.
Hi Ted, my name is Angela. I'm one of the PAs with the palliative medicine team. And Dr. Snyder and I are working with your family to get you comfortable and get you feeling a little better, okay? And Dr. Snyder, I was looking at the medicines that he's on. It looks like he's getting some IV fluids and propofol.
Yes, he is.
Okay.
He's likely deeply sedated, but I understand that we're gonna be proceeding.
Yes, I believe that the family is going to want to proceed with transitioning to comfort-focused care.
Okay.
So if we could start weaning the propofol, I can put in some comfort extubation orders in preparation of that.
All right. Well, all right. Well, let's go ahead and put those in, and then Jane, can we bring the family back?
Yeah. What do you think you're going to use for pre-med?
Let's go ahead and pre-medicate with some morphine and some Ativan.
Okay.
And I'll put those
How much
orders
do you
in.
want?
Let's give 2 milligrams of morphine and 1 milligram of Ativan.
Okay. He had succinylcholine and etomidate before.
Yeah. So those
So
will
that should be pretty much out of his system
Yeah.
at this point.
Yeah, the succinylcholine is
Okay.
probably about 7 minutes.
Okay.
The etamidate's
Right.
about 30.
All right. So I'm going to go ahead and bring them back because they really want to see him
Okay.
before they extubate. Is that okay?
Yes. Thank you.
Okay. I'll go
Thank you,
catch him.
Jane.
Remember I told you he had that breathing tube in his mouth, so I don't want you to be alarmed, but it's him.
Come on over, my little Sophie. So you can see that he's got the breathing tube in, and he's on a few
I'm gonna
different
get some
medicines running through the IV. He's getting some fluids, and then he's also on a medicine called propofol, which has him sedated. So we're going to start weaning that medication off of him and start transitioning to some other medicines like morphine and Ativan to control his symptoms.
Wait, I mean, I know we want this tube out, but I remember my grandma died a couple years ago, and I feel like the morphine just made her just die faster, and I don't want that for him either. I want it to be just natural, and I want him to just be.
And we want to allow him to have his natural trajectory too. But we also want him to be free of suffering and pain. And when medicines like morphine are used in appropriate doses to help prevent suffering and pain at end of life, they do not hasten death.
Okay,
And that's really our priority for him, is to manage those symptoms.
okay, thank you. Hi, Dad. Thank you.
I'm going to let you all have a moment with him, okay?
Okay.
He'll be just around the corner. Whenever you all are ready, Dr. Snyder is going to remove the tube, and we're going to give him some medicines beforehand.
What are we gonna do when when he takes the tube out?
Can we stay?
Can we stay?
You are more than
Okay.
welcome to stay if you would like to.
Okay.
Just remember that when the tube is first removed, until we give him medicines, he could have some symptoms of shortness of breath or looking like he's breathing fast. So if that's something that you don't want to see, I would have you step out.
Okay.
But if you would like to be here with him, you're more than welcome to sit here and hold his hands. Jane is going to come in to give the pre-medication, and then Dr. Snyder will come in to remove the tube.
Yeah. Okay, so I've got the morphine. Oh,
Doc, can you make sure the propofol is off?
yes.
And the IV
It's on.
fluids could be turned off too.
Okay.
Order for morphine.
Yes, you can go ahead and give the morphine.
Okay.
As soon as the propofol's been off for 20 minutes, we'll go ahead and do this. What medicines have you administered already?
He's had the morphine and the Ativan.
He's had the morphine and the Ativan. And go ahead and have some ready PRN. What would you recommend?
Yep, I would go ahead and have some more morphine and Ativan ready in case we need to
Yes.
push more.
Okay.
Go ahead and pull another 2 milligrams of morphine.
All right. So we'll go ahead and extubate him, and then Jane, right after we do it, would you mind going ahead and bring the family back here expeditiously?
Absolutely.
Okay. Jim, can you silence go ahead and silence the alarms on the ventilator? And can we turn this off? Please turn the vent off. Let's go ahead and set him up a little bit. Jake, you go ahead and give him another dose of morphine.
Yep.
He looks like he's having some respiratory distress.
Got it. It's in.
Okay. Let's bring him up a little bit more, and Jane, if you could get some Robinol to help with some of the secretions, and repositioning will help as well.
I've got some of that here.
You want to put him on his side or put his jaw forward? What's the positioning you like?
Let's try his head back first and open his airway a little better, and
Okay.
then if that doesn't work, we can turn him over.
Okay. Jane, can we go ahead and get the family? I'd love
Yes,
for them to be
yes.
here.
Yes, they
I don't
need to
think
be.
you.
I'll be right back.
Thank you.
I'm giving him some medicine for the gurgling, so it's gonna get better in just a minute, okay? And he's had a little bit of extra medicine since we got the tube out. Just because he was struggling a little bit, you know, there's a time of transition when we get the machines off, that the body just has to get used to breathing on its own.
Can he hear me?
You know, I don't know is the right answer, but what I always tell families is talk to him like he can. So you just talk to him and say whatever you need to say.
Why do I? Monica, can we pray with him?
Of course.
Can we? Thank you.
So he has passed.
Oh.
Many families often have questions about what comes next. When you're ready, we'll meet you outside the room
Yes.
and try to answer some of those for you.
Okay,
Our
thank you.
condolences.
Thank you.